Okay, we're live. Welcome to Labor and Health on this Good Friday morning. Everybody in the audience remember my rules? I should make you good. Oh, Chairman, you haven't heard my rule. If you have a cell phone, please turn it on. Because if it goes off, you buy donuts for Monday, or if not for Monday, for Wednesday next week. And we haven't had donuts yet, but if you do have to buy donuts, we prefer chocolate glazed and maple glazed. Absolutely. Absolutely. I'll eat every one of them. The Health Committee. Okay, committee. The first bill we're going to hear this morning is House Bill 140, Mental Health Care Access Collaborative Care Model. Chairman Zwanitzer.
Thank you, Mr. Chairman. Let me just make sure you don't do roll call in the Senate.
We can look and say, yep, we're all here.
Okay.
We're here.
Well, good morning, Chairman, members of Labor Health. So, I think this is my first time before you, but we're going to have a long interim and look forward to working with this committee, with the Labor Health Committee in the House. Today, I'm bringing to you House Bill 140, Mental Health Care Collaborative Care Model. And I believe you've hopefully all gotten some information about the actual model. The bill is pretty simple in what it does. Really, we're defining mental health and substance use disorder benefits there on the bottom of page 1 in Romanet A. And then on page 2, lines 18 and 19, we're basically using the collaborative care models defined by the AMA as what we'd call, we're placing this in the Insurance Code of 2620, which are mandated coverages. So really, it boils down to it's a financial coding process, right? And so the procedure we're asking to do takes one mental health specialist, shall we say, psychiatrist, et cetera, and you can share their time at a wider range than having to meet one provider and then getting a separate appointment to meet with another provider. This allows more of a collaborative care model that would allow consultations without sending a patient, in many cases a juvenile, to multiple appointments and multiple billings, and so they can share information back and forth. And so we're just allowing this type of kind of insurance-based coding, which should increase access to care. As I'm sure you're all aware, we have significant access issues in Wyoming, especially for mental health, especially for juveniles in the state. It does probably at this time, and I'm sure the associations behind me will testify to a greater degree, but there's only 2 areas of the state looking at that, kind of using this model right now. One is in my home community in Laramie County. The other is up in Center Dockstader's part of the world. Certainly, if it works well, more hospitals could take this type of model on. But I do think it's great with a severe shortage of mental health providers, psychiatrist level, who can prescribe medications. Here in Laramie County, we have, I think, 2, and I'm not sure either one lives here in town. They travel and they visit as part of a greater kind of span of coverage. And so anything we can do to provide greater access to services and let patients stay with kind of a doctor they trust who can consult with a psychiatrist or a medication provider for specialized mental health care, I think is important. That's generally what the bill does. There's some rules and regs, requirements for the department on section 2, and they're also here, and then it becomes effective immediately there on page 4. Happy to answer any questions on it. I know there are people here who can talk about the model in more depth behind me.
I believe, Mr. Chairman, the ICD-9 coding is already in place. I believe the codes exist. We just have to put it into use. Is that correct?
Yes, Mr. Chairman, I believe 8 other states have already adopted this model, and others are working towards it here this year. It has kind of amazing results that have been shown in those 8 states. I think 2 are new, but some have had it for 4 or 5 years. Provides greater access, greater recovery, greater access to care and better outcomes for those patients. And certainly the people behind me can testify to that.
Very good. And I correct myself, ICD-10, not ICD-9. Yeah, okay. That being said, questions, committee. Senator Barlow.
Thank you, Mr. Chairman. So I'll have some, well, first of all, Mr. Chairman, if I could just remind you and remind the audience that I have a bill up in another committee, so I'll be departing this committee in a little bit. But so my question is there a prohibition or a indication that this would not already be offered through carriers without this legislation? Because where this is placed in the statute, This is, where we're requiring certain services or certain benefits. And so my question is it not already being voluntarily provided? Thank you, Mr. Chairman.
Chairman Swanser.
Mr. Chairman, Senator Barlow, I'm not sure if it's already being provided. Certainly, this is the mandated insurance coverage section. And so I believe, yes, if an insurance company would agree that it could be. As you probably all know, we only have, I think we're down to 4 covers in the state. And so if none of them had this program, we wouldn't be able to have the model here in Wyoming. So yes, in theory, in other states, it might be possible. As of now in Wyoming, I don't believe this is allowed under any of the current insurance plans until we have this legislation in place.
Thank you. Further questions, committee? Senator Bouchard.
Thank you, Mr. Chairman. So my question is on outpatient services on mental health. What I looked up was, I found it was like $594 per patient savings. And I'm just trying to figure out, where we are with this fiscal note and total numbers.
Go ahead,
Mr.
Chairman Swanson.
Chairman, Senator Bouchard. And so the fiscal note itself is the effect on the state employees insurance plan. And so, this is a new model. We had a revised fiscal note. Originally, they thought the cost of services by doing this would be 6% across the board after consultation with employee group insurance. So the department insurance, I think we checked with them and said, no major fiscal note in their belief. But when you talk to employee group insurance of the state of Wyoming, which our LSO department does, when we talked to them about this may only affect 2 areas, they revised their fiscal note. But I would say that's a guess on their part, just when they looked at other states. And so certainly people behind me can talk about that more on the actual fiscal note, but it's not a hit to the general fund. It's an effect on the state insurance plan, which are always interesting to me on fiscal notes.
Further questions?
Follow up, Mr. Chairman.
Follow up, go ahead.
So I did some looking, and I see the whole effect of how this works. Other states have done it. I mean, diabetes is one of the biggest factors that they have found. I mean, it's kind of the same argument that the optometrists make. They always can find that when it's missed somewhere else. Is how much of this fiscal note do you think if we go back there and pound on them, we can get this down? Because I mean, it seems to me every time we go and try to change something, we've got IT people and we're paying all these salaries already. Maybe they can just work a little harder on this and maybe try to get this fiscal note down. Is there a possibility?
Mr. Chairman, Senator Bouchard, I think you'll hear from the research and studies this actually saves money. So that fiscal note is just on the employee group insurance. And when you look at all states, not all states actually even add that as a fiscal note. And it's something we did about 12 years ago to kind of encourage anytime a bill might affect employee group insurance plan to add that as a fiscal note, which I have never really agreed with, honestly. So no, I don't believe that fiscal note. I think after a couple of years if this model goes into effect, there's been other states that it's been shown to save money. So I'm not in agreement with the fiscal note. It has been revised and a lot of consultation on what the effect on the employee group insurance plan would be. I personally don't think there will be one based on what other states have seen, and certainly people behind me can testify to that as well. So I would encourage you not to be afraid of the fiscal note. It's a guess based on 2 counties who might use this model on what that cost might be. It's a pretty, I hate to call it a wag, but it's a guesstimate. It's a fair way to say it.
My suspicion is that this, in the long term, probably not even all that long term, it'll produce a savings, because rather than all the separate billings, where they're combined, and a more efficient system, but that's just my guess.
Mr. Chairman, can I just clarify? I don't believe the fiscal note either. So, I mean, I've looked at the program on a bigger scope outside of Wyoming, and I didn't see the arguments in other states to put a cost on it because of the savings when we're taking care overall of people's care. So
We like savings on this committee.
In the Department of Health, certainly we do, and I think the Department of Insurance is here And you could check with them on, I think they've researched some other states on if it actually costs money or saves money. I think fundamentally, when you look at the process, it will save money, patient time and access and better outcomes. Long-term, that certainly saves funds.
That's all of our goals. Okay, with that in mind, you've got the seat warm. Committee, are there any further questions, or should we move somebody else up? Let's move somebody else into the warm seat. Stand by, representative. Okay, departments. We have a couple, 3 departments here. Who wants to be first, or who wants to speak? There we go, yeah. We require anybody that's in the room to speak in this committee, so the doors are now locked when you came in. Go ahead, sir.
Mr. Chairman, members of the committee, my name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program. Just wanted to talk to the fiscal note. The plan in 2021 spent roughly $10.3 million in mental health care. What we looked at this particular piece of legislation is expanded access, which I agree is needed in this state. I do agree that you can, with coordinated care, you can get better outcomes, but better outcomes don't always mean it's less expensive. So our access was, we came up with the $458,000 for the fiscal impact beginning in 2024.
Okay, questions, committee? Senator Bouchard.
Thank you, Mr. Chairman. So I looked outside of Wyoming and I didn't see other states having this approach. And what I saw was, and I could see where you could say maybe that the outcomes aren't taking us down a better road, but if you find something early, it is better overall because the cost goes up as it becomes more urgent. So what kind of guess did we use to do this? That's what I'm trying to, because we see this a lot. We see a good program, something that could work very well, and then we see a fiscal note, and we're always trying to go, well, how did we come up with this? How did we not offset this with what we know in other states? There's 60 studies on this. I mean, so it's not new. So
Go ahead, sir.
Mr. Chairman, Senator Bouchard, basically, again, we just approached it from an expanded access point and more visits, ultimately, is how we approached it. Better outcomes in this particular area, being mental health. More visits generally get people more stable. It also helps them maybe maintain employment. There's a lot of good things that come with this, but that doesn't mean that it is free.
What I would add to that is I suspect that although it may increase the visits, et cetera, but you were actually reducing, it'll reduce the visits to their primary care perhaps. It'll reduce their visits to the ER. That's my own assumption. Some of the other folks who speak to that, but I understand what you're saying. But my guess would be that in the end, the total number of visits to everybody will probably reduce because now we're going to a joint care. And that's my wag, if you will. Okay,
Mr. Chairman, I would agree that that is a potential, yes.
very good. Okay, Senator Hutchins, go ahead.
Thank you, Mr. Chair. Excuse me, Mr. Hayes. Come in, you give us a figure a lot, and you don't give us any data with those figures that kind of help us make an informed decision about how you reached your assumption so that when I'm going to vote on this bill, I can say, oh, he came up with that figure because he did this, he added this, subtracted that, multiplied this. You just come in and say 10 million or 5 million, 4 million, and then you walk out. How can you help us understand really how you get your figures? We're kind of going down a rabbit trail with this, really, but I'd like you to provide us with more information than just coming in and giving us a figure and then walking out. I'd like to see how you reach that assumption maybe later. And we've asked to get this information maybe in email or some other kind of form. Could you provide that with us so we don't have to continue with this portion, the fiscal note? But it would be nice to know how you came up with your assumption.
Okay, you can answer that
Thank
if you
you.
wish, but what
Mr.
I would
Chairman,
state to the
members of the
committee is,
committee,
We got to be careful not to confront the witnesses. That's fine to ask a question, but let's not confront them
Oh,
and
I
be
don't, I'm
argumentative.
sorry if it feels confrontive.
Yep,
It's
okay.
just, my
Go ahead, sir. You may answer that if you can.
Mr. Chairman, members of the committee, basically, as I mentioned, we spent about $10.3 million back in 2021 over the calendar year for mental health. So what I did was take that and I took it times 15%, assuming that would be the across the board, which came up to $1.45 million, and I rounded it down to the nearest $1,000. Then I assumed a 6% trend to bring it up to fiscal year 2024, 25, and 26. And once I talked to the committee members on the fact, I was assuming an entire statewide rollout on this, but seeing it's only in 2 areas at this point in time, I reduced it by 3/4.
Go ahead, Senator Bouchard.
thank you.
Mr. Chairman, thank you. So going backwards, because that year is a COVID number there. So I'm curious, going back, if we look backwards, isn't it a lot, is it lower? I mean, where are we at going the year before that and maybe 2 years back?
Mr. Chairman, members of the
ahead.
committee, the year before was roughly 9 million. So what we're seeing is, like most of healthcare, the costs keep going up.
Further questions, committee? Okay, thank you very much. Somebody else needs to jump up in a seat. Who wants to come up? No one. I'm really disappointed. Oh, here comes one. Welcome to the committee. Go ahead and introduce yourself and tell us what's on your mind.
Good morning, Mr. Chairman, members of the committee, Sheila Bush with the Medical Society. I usually try to bring a physician with me for this bill, and I tried to do that in the House. They're very busy today. Friday is a procedure day, I've learned, so I apologize, you just get me, and I will do my best. So this bill, we see as a very simple bill. It's an evidence-based bill that allows physicians to provide care in a way that's better, that has produced better outcomes and saves money. And I can go into some of that savings. We have a Milliman report from 2017 that I think will help inform some of this. Before I get started with my overall sort of comments, which will be brief, there were some questions I thought would be just good to answer. One of them was for Senator Barlow, who's not here anymore, but he asked, is anyone paying for this now? Right now, Medicare pays for this. Medicaid does not yet, but we're hopeful that will happen within the year because of some other things happening in the behavioral health community. And this is for private payers only. And this bill really is a baby step in. This doesn't cover those individuals who are insured on the exchange for a variety of reasons, most of which sometimes that triggers something called defrayment, and we didn't want to have to go there. And so this really is for large group plans over 51. And so it's a baby step. We are confident that, as we've seen in other states, as insurance companies get a little bit of experience with this model and they realize the savings, that then they can voluntarily open these codes to those members on the exchange, and that's truly the hope. And so this is, you could think of it almost as a pilot. So it's a pretty small group. It's not a wide, broad mandate. It is a mandate for large group plans that are insured as a large group and would qualify under this provision of the state mandates. And so that's just a little bit of that piece. And that also speaks to why we need the bill. Sometimes you need legislation to start the conversation. Insurance companies are not opposed to this, but we worked closely with them through the summer and interim to get there. They started with a little bit of reservation and hesitancy because our insurance companies are familiar with a world in which medical care is reimbursed on something we call fee-for-service. And so in a fee-for-service model, one provider bills one code for a patient, and that's all very, it's outlined in their claims processing. Insurance companies believe that there's a little bit of control there and that they have a sense of transparency in what is happening in an exam room. This model is different in that it turns the corner into something we call as value-based care. And so providers are reimbursed in this model really on outcomes. And so they have to prove through the registry and through their management software that they're doing what they're saying they're doing, but it's not based on the CPT code that is very specific. there's, Senator Baldwin can tell, ICD-10 has thousands and thousands, hundreds of thousands of codes, and they're very specific. And insurance companies really like that model because there is this notion of maybe not control, but transparency. And this turns that corner into a value-based care where an entire team wraps around one patient and delivers care in that primary care setting. And so any patient, whatever their need is in that moment, can be addressed timely without them having to leave the primary care clinic. They can stay there and get the subspecialty expertise if required, but they're staying with that one trusted provider. And so the reason that that's so meaningful for us is that you don't have the stigma that sometimes is associated in small communities with being referred to a mental health provider. You hear sometimes in this committee a lot about this idea, I would have gone to a mental health provider, but I didn't want anyone to see my car parked in front. This eliminates all of that. In Cheyenne, our pediatric clinic is the one who is pursuing this. They have hired or contracted a child adolescent psychiatrist who will start in August, and that individual will be embedded in the Cheyenne Children's Clinic. And so why that's so valuable is that psychiatrist will be in the hallway with those, I think there's 14 pediatricians in the Cheyenne Children's Clinic right now. Those 14 pediatricians will maintain the relationship they have with their patients and those families. Those are trusted spaces that they've built through time. If any of those children need more care that is of a specialty nature, that is beyond what a pediatrician might believe was within their scope, they have that consulting psychiatrist right next to them, and they can elevate that patient into a collaborative care model, and at that point it becomes a team-based care approach. And so just to finish what I was talking about with the value-based care, the reason that you have the bill is to start the conversation, and the reason insurance companies are a little nervous about a value-based care model is that these codes then are just for how many minutes that team collectively spends delivering that care for the patient. So there's 4 codes. I can give them to you, but it won't matter. They're 99492, 93, and 94. And they're the number of minutes. So the 99492 is 70 minutes. It's an intake visit. And then there's a whole team that they kind of addresses accountability for what's done in those minutes, and that's in the registry for transparency purposes. And so patients get better faster. And that's why we believe it's really a good model. I have a Milliman report that I can give you, or I can give you just a couple of points from it, and then I'll finish. But in a study from January 2010 through December 2013, patients in team-based care had 11% fewer hospital admissions, 23% fewer ER visits, 7% fewer primary care visits, 2% fewer specialty care visits, 1% fewer urgent care visits, and 3% lower total healthcare costs. And so it really is, it's a model that we feel good about. The evidence supports it, and we appreciate your support.
Questions, committee? Senator Dockstader.
Thank you, Mr. Chairman. Ms. Bush, my understanding then just 2 locations dealing with this now. It's the Medical Society. Why are they slow to take this up?
Ms. Bush?
Mr. Chairman, Senator Dockstader, I don't know that we're slow to take it up. The model was sort of founded or born in the early 2000s out of the University of Washington. It was initially modeled for an older adult population, and it was first explored, I think, just for depression and anxiety. And so in those last 20 plus years, it has expanded. Now it's widely used in substance use. It's been proven to be one of the more effective ways of treating individuals suffering from any sort of substance use disorder. We're just not that great. I don't know. This is brought to you primarily by the Psychiatric Association. It's a very small population of physicians, and the Medical Society is partnering with the Wyoming Association of Psychiatric Physicians to bring the bill. I think it's painful for medicine, all of medicine, to turn the corner from fee-for-service into a value-based payment. It's an unfamiliar space. There's some risk associated with it, and really, for them, and to make this model work, you have to really commit. You have to build the registry. A pediatric clinic has to hire a psychiatry a specialist to be embedded in the clinic. Those are all expensive things. It's hard to recruit. So I think it's a variety of things. Yeah.
Senator Hutchins.
Thank you, Mr. Chair, and Mrs. Bush, I thank you for coming often. I mean that.
Thanks.
So I'm gonna picture this in my mind. We have a pediatric center, and there's a psychologist in there. And am I thinking of adults clandestinely coming in and seeing this psychiatrist, or is this for children? That's question number one. And then number two, I'm seeing also in my mind, a child is there for one reason, and there's a doctor there for that, and then, or a person, and then there's psychiatrists there, and maybe somebody else there, and they're all there together, or maybe one is there and they walk out, and then the other one comes in and deals with whatever is ailing this person, and then they bill under one code. Is that what am I getting it correctly, or what?
Ms. Bush.
Mr. Chairman, Senator Hutchings, to your first question, I don't believe there is a concern or a risk that someone not already being cared for in a primary care clinic would then start coming to the clinic to receive services from the psychiatric professional that is there. And I don't know if that was your question, but I don't think that that's the risk.
Well,
ahead.
Mr. Chair, you mentioned that some people didn't want to go to psychiatrists because of the stigma behind it. So that's why I was wondering, is the psychiatrist there in that pediatrics clinic so people can come and see them without really, hey, you're going to see the psychiatrist? That's what I was wondering, because I thought that's what you mentioned.
Thank you for the clarification. No, not quite like that. I think, so one important, and it's a little in the weeds, and so I hesitate to go here, but one thing that's really important to differentiate and might be important to talk about kind of the specifics of how each of these models can be stood up a little bit different to meet the needs of a community. So for example, here in our pediatric clinic, when that psychiatrist comes, you have to get these models off the ground, right? And so until that's really going, that psychiatrist can have a private practice within pediatrics. So if there are pediatric patients who need psychiatric attention, this physician will be able to address those. And that's called, that would be within the traditional fee-for-service model. So then as the collaborative care model comes off the ground, if a primary care physician identifies a patient who would be a really good fit within a collaborative care model, they have to technically enroll that patient in the collaborative care model. That's at the time at which a patient gets identified in the registry, and the team kind of comes together. And then it's my understanding that that patient then receives the services of all of the people on that collaborative care team. So there's a care manager who's a really important component of that. And they can intervene therapeutically. They can help case manage. They can answer a phone call from a mom later in the week when there's a question about a medication. And so the primary care provider remains the primary individual who's delivering the care. They consult the psychiatric provider for advice, medication management, questions that they have that might be outside of where they're comfortable, all of those things. And so that team can meet on the basis that they see fit for each of the patients who are enrolled in the collaborative care model. But what's important to understand is once a patient is enrolled in the collaborative care model, the psychiatrist is prohibited from generating individual codes in the fee-for-service model on that patient. And that's there in place for a variety of reasons, not the least of which is to make sure that there isn't any risk for fraudulent behavior or billing within the model. So if you're a patient who's in the collaborative care model, you cannot file a claim as the psychiatrist for an individual visit with that person. That psychiatrist can see the patient, but only within the context of the collaborative team. Does that make sense?
Oh, yeah.
Okay.
You really cleared it up. Thank you,
Okay,
Mr. Chair.
yeah.
Yeah, very good. Further questions, committee? Nope, very good.
Thank you.
Have a seat. Anyone else here wish to testify? Senator Schuler, you snuck in late. Go ahead, Senator.
Thank you, Mr. Chairman. Sorry for not being able to be here at the beginning, so I hope I don't say anything that's already been said, but if I do, oh well. Appreciate you hearing this legislation or potential legislation this morning. I think on my side of things, as you well know, being from our corner of the state, we have some unique challenges with the state hospital right in my community and very close to yours. And this collaborative care model, when I first heard about it, I thought this might be the real deal to really help us out with some of the issues. What we see happening quite often in our community is we have folks that get released, from the state hospital. They end up in our community quite often, and maybe they do well for a little bit. There really isn't a very warm handoff, quite frankly. Not a lot of follow-up, and I'm not really blaming anyone for that, but sometimes these folks end up maybe going off their meds or having other things that happen within the community. And then we end up seeing them in our jails and our detention centers and that sort of thing. Then they get out, they try to, make some type of contact with the primary care person, and sometimes they can get in fairly soon, sometimes not. We do have a shortage of mental health providers. That's the problem here. And this collaborative care model is a team. I look at it as a former coach. It's a team concept. It gives these folks a chance to be able to not just be seen by a primary care physician and have them try to help whatever's going on, but it gives them a chance to connect with a primary care, a psychiatrist, a care manager. Excuse me, I'm losing my voice. And the team, I think, concept is what might help them get over the finish line and be able to get back into society, whether it be in our community or whether it be someplace else. The studies that I've done and the research I've done on this, it appears as though it really helps with decreasing the amount of folks that end up back in our ERs. I think it's about 54% less ER visits, about 49% less inpatient psychiatric care issues. And I don't want to reiterate, which I'm sure some of the things have already been said, but just integrating the situation, this person into a team where it's not just me and my primary care, who I might be able to see in a timely manner, I might not. But hopefully when I do get to see them, this model would help us to be able to feel like there's some other help out there. There's some other advantages and I think, and nothing against primary care physicians, because I know Dr. Baldwin up here would be upset if I did that. I appreciate all of them they're in the highest regard as far as I'm concerned. But I think it's difficult, psychiatry is not it's not their chosen field generally. And I think sometimes, we throw a drug at this person after they've been seen, and sometimes it works and sometimes it doesn't. And so having that team concept where we have the access to a psychiatrist and we can get some answers back and forth, and we can say, well, this is working, this isn't, and have that care manager as well. I think it's not only gonna help in my community, but I think it'll help in other communities. And I'm not sure if we have folks in our community that would want to set up one of these clinics. I hope we do, because we need it probably as much as anybody in the state of Wyoming, in my corner of the state. So with that, I don't want to reiterate, which I'm sure many of these things have already been discussed, but very much in favor of this legislation. I'd be happy to answer questions if I can.
Thank you, Senator. First of all, I correct you. PA Baldwin, not Dr. Baldwin, but that's okay. We won't hold it against you. Although I said, those people buy donuts and misspeak. Is that correct?
I call you Doc.
That's what you missed it when you were late. Any questions for Senator Schuler? No questions? Thank you,
Thank
Senator.
you.
Okay, further testimony. Welcome. How are you this morning, Josh? Go ahead.
Good, Mr. Chairman, thank you. Members of the committee, Josh Hannes with the Wyoming Hospital Association. I'll be very brief. We do support this legislation. We think it's a good model to deploy resources and effectively deliver care. I think, as you heard earlier, we have 2 of our member hospitals that are ramping up to begin this work. And there's 2 clinics in Cheyenne Regional, I believe, and then also in Star Valley, who are excited to begin this work. And I would also say in another part of my life outside of my day job, I serve as the board chairman of our local federally qualified health center. I spoke to our executive director. They provide some mental health services as well. They're interested in taking a look at this model. So I think the benefits could extend to a number of different types of facilities. And with that, I'd stand for questions.
Questions for Josh Committee? Seeing none. Thank you very much.
Thank you.
Further testimony? Seeing none. Nobody online for this one, I don't believe. Committee, what's your pleasure?
Move the bill.
Moved by Senator Dockstader. Okay, committee, let's work through the bill real quickly here. It's a white bill, which means they didn't change anything in the House. We like white, clean bills. And they like us to keep them that way if we can, but if we can't, we can't. Anything on page 1, committee, you can see. How about page 2? Page 3. Final page 4. Seeing no, any suggestion amendments or comments, committee, anything you maybe like to share? Senator Dockstader.
My home area was referenced as one of the areas starting this up. Had some initial discussions with my healthcare providers. Already starting to mix it because you have a situation where your physical health and your mental health often tie in together. And early comments are it's a very positive program. This allows us to put it on track, to get it in statute and get it moving, and perhaps more than just a couple of locations in the state will consider something that's already successful. I'll be on it for the bill.
Further comments, committee? Seeing none, I agree with Senator Dockstader. I think it's a great model. It's a great step forward. It's a baby step, as somebody said. It's a start and there'll be further steps, but it's an important step. And I think it draws things together. I know we tried this in my clinic for a while. We didn't use these billing codes. ICD-10, we could have a whole committee meeting on ICD-10. She talked about how complicated and how many there are. That's an understatement. There's a lot. Anyway, it's a good model. It works good to have everything under one roof when you can. So with that, let's go ahead and call roll, please.
Thank you, Mr. Chair. House Bill 140, Mental Health Care Access Collaborative Care Model. Senator Barlow is an aye. Senator Bouchard, Senator Dockstader, Senator Hutchings, and Chairman. Sir, we have 5 ayes.
Passed the Labor and Health Committee.
Who would like to?
Representative Schuler, stick with us. She ran away, didn't she? I bet she's going to present this on the floor. though.
Thank you.
And privilege of the floor, Mr. Chairman.
Go ahead, sir.
I spend a lot of time in your community, and every time I reference that I know you, they refer to you as Doc Baldwin. So
I know.
so you're there whether you want to be or not.
And they don't buy me donuts either. Okay, that brings us to the next bill. And I just asked the prime sponsor of the bill if he was going to be here to present. And I guess he's not because he's in Denver on his way to DC. So I guess that means I'll present this bill. Oh, there we go. Our favorite presenter. Actually, you've never presented in this committee this year. Welcome. We wish you were up and running and trotting around, but you will be. You will be. Welcome, Representative. Go ahead. And
Thank you, Mr. Chairman. I am here not because I'm on the bill, but because I had a similar bill in the House that happened to fail. And so this is another opportunity to get this legislation going. And I'm going to depend on my experts in the room for a lot of this. But what the problem we've seen in my community and probably in
yeah, go ahead and introduce yourself.
Oh,
And you know what
Representative-
else? I forgot to
I'm
say
sorry.
which bill we're doing. This is House Bill 108, sale of THC vaping devices and edibles to minors prohibited. Go ahead and introduce. We all know who you are. but-
Representative Sandy Newsom from House District 24. Thank you. So the problem we've seen in our communities, probably your community as well, is specifically a substance called Delta 8 being used by our high school students and sending them to the hospital, oftentimes in an ambulance. And so what we're trying to do with this bill is to make it so that the age for purchasing these products would be 21. And instead of playing kind of whack-a-mole, because with Spice several years ago, there was legislation to make spice illegal. And then the clever people who develop these drugs just develop other ones that don't fit whatever the definition is. So what we've tried to do with this bill is to make the age to purchase those products be 21, but to also take in, by definition, chemically synthesized, a range that would not just name one particular product, but name a group. And so as we would go down to, so a lot of this is consistent with tobacco products and the age restrictions on those. But if you look at page 6, lines 4 through 14, we've expanded that definition to hopefully gather in all of these products and future products that will be chemically synthesized to make them so that people over 21 would be available for them to purchase, but people under 21 would not be available. This is specific to vaping products as well as edible products. So that's kind of the gist of it. And with that, I would stand for any questions, and I would like my friends from law enforcement to come up and add their expertise to this particular
Thank you,
topic.
Sandy. Were you present when it was presented in the House?
It was in my committee in Travel, Recreation, Wildlife.
Oh, very good, very good. And my question to you is, I'm looking at the amendments that you made, which there's a pretty good length of them.
So the
Can you
amendments.
Tell me about the amendments.
The amendments were to expand the products that would be regulated under this.
And I asked because these look similar to some that were brought to me to suggest that they look the same, so I'm assuming they are.
Right.
Okay, questions for Representative Newsom? Senator Hud? Go ahead, Senator Hutchins.
Thank you, Mr. Chair. Representative, in the area of tobacco, I may be a little bit knowledgeable, but the THC products, just looking at this, it's kind of worries me a little bit when we're talking about being 21, or bringing THC into Wyoming. I believe THC is in marijuana. So my question would be, by passing this, are we in a roundabout way bringing the okay stamp for marijuana uses to come into Wyoming?
Mr.
Representative
Chairman,
Newsom.
Senator Hutchins, no.
Okay,
What we passed several years ago was hemp. Hemp can contain up to 0.03% THC. So by virtue of passing that hemp law, we have, in one way, said that 0.03 THC is fine. What we did not anticipate, or I didn't, when we passed that bill, was that there would be these synthetic, chemically changed products using hemp as a base
Yeah.
that would then make that THC more available to alter people's perception. So that the challenge is that we, the federal government and the state of Wyoming, said that it was okay to have hemp. I think we did not recognize the ramifications of
Yeah, and
that at that point in time.
And I would add that these are not derived from the cannabis product. These are purely, I apologize for my voice again. These are purely synthetic, entirely synthetic, not derived from the hemp or from the cannabis plant. Go ahead, Senator.
thank you, Mr. Chairman. I appreciate that, and I just wondered, because when, I'm not gonna say we passed the hemp law, because I was totally against it, because I thought this is what would happen, and it did. So, yeah, I think you answered my question. I may have a couple more, but thank you.
Thank you.
Senator Dockstader.
Thank you, Mr. Chairman. Representative, I understand you said you had another bill similar to this that was your bill?
I had a bill that was a little broader reaching, that
Can go through.
that did not specifically say edibles and vape, it said anything.
Okay. So
And-
my
and-
question is, you obviously feel strong enough about this that you're selflessly supporting this other representative's bill now. Why do you feel so strong about all this?
Well, because kids in my community are going to the hospital. And I think we might have a few of them online.
Okay,
Some of the youth, you're familiar with the Youth for Justice group
right.
in Cody, and they're adamant.
Thank you,
About
Mr.
this.
Chairman. Just impressed that you're picking up somebody else's work and making sure it goes through. Thank you.
And he did say thank you, by the way, as he was getting on the airplane and doing.
Thank you.
Further questions for Representative Senator Hutchins?
Thank you, Mr. Chair. Really quickly, is there anything from your bill that you would like amended into this bill?
Well,
Go ahead.
Mr. Chairman, Senator Hutchins, we kind of looked at that and it became awkward
Yeah.
and it didn't quite fit.
Okay.
So that the expansion of the definition was brought from that bill, but they were different enough that it didn't quite fit.
Gotcha. Thank you.
Further questions, committee? Senator Bouchard.
Thank you, Mr. Chairman. I have a problem with the 21 age limit. I mean, because what I'm trying to figure out here is this legal otherwise to people, to adults? I mean, if it's bad, how come it's not outlawed, period? And two, in your county, we had an agency that couldn't tell the difference between different items in the CBD world. And they made an effort, a run in and try to get pushed back on the hemp products. And I'm a little concerned when I see some of the language in here that looks similar to the hemp products, CBD products. So how do we not get into that again, where we're having that problem? I mean, you had a police chief up there in that county, we talked about, I think, a spectrometer where we could look at THC, and I looked them up, they're about $2,500. They spend thousands on traffic ticket meters. We couldn't spend $2,500 to determine if there's THC in a product. So how do we know that it's not a gummy that's like, for instance, CBD that doesn't have this product in it? I just don't want to have another mess to the people that use CBD products for, other ailments.
I think there were two questions actually in there. The first one was those over 21 is illegal, and then the second part of his question, is that correct? Go ahead.
Thank you, Mr. Chairman. Thank you, Senator, for that question. I think that the challenge is that there are those CBD products that may contain that 0.03% and less and are perfectly legal. And in my bill, the prior bill, I specifically exempted topicals. So anything that was a topical treatment with CBD was not included in the bill. The second question of how do we determine how much THC there may be in a product is not easily answered because the science behind that is not as precise as we might like it to be. And so I believe that my good friends in law enforcement have stated that when there's a testing, the margin of error is more than 0.03%. So the testing piece is unreliable. And then you get into that, is it or isn't it? The age, the 21, is just consistent with other addictive products, alcohol and tobacco.
Thank you. Further questions? Follow up?
Thank you, Mr. Chairman. So on the test equipment I'm talking about is mobile. So other states have put those in police cars and they can actually, so we have a scenario where we have a legal gummy that has CBD, and then we have these other ones that have this product. Now we have potentially an officer arresting someone or going after that product that's actually legal. And so we're putting the officers at risk, because they're going to end up in lawsuits. anyway, so in the end, we're also pushing back in the industry that we've advanced. So that's where I'm looking at here. I want to know how we're going to get down and nail down to, well, this one's illegal and this one's not.
Okay, response? Go
Mr.
ahead.
Chairman, I think that my law enforcement friends can maybe better answer that than I can.
Okay. With that in mind, let's bring your law enforcement friends up.
So I can phone a friend.
Yeah, that's right. Phone a friend, lifeline. They've been wanting to jump out of their chairs for quite a while now. Welcome, gentlemen. Oh, do we have any more out there that want to come up with this group? We got 2 more chairs. Okay, we'll fill one of them. Come on up.
Has her own chair.
Okay, whichever one of you would like to start. Mr. Odekoven, go ahead and introduce yourself.
Mr. Chairman, thank you. Byron Odekoven, the Executive Director of the Wyoming Association of Sheriffs and Chiefs of Police. And I have with me Rhea Parsons, who helps with our marijuana and drug education efforts that we've had within the association for years, dealing with dangerous drugs and the education of the public and officers alike. I also have Detective Hedham from the Cheyenne Police Department, and I believe that there's a sergeant from Casper, I hope, is online as well, to round out our discussion and presentation in terms of the issue before you with the adulterated CBD products that we now have and need to deal with. So let me do a small introduction, turn it over to our detective and sergeant for some explanation of the problem, and then come back, if you will, to talk about how the bill helps in that regard and helps address the issues. So we have, to set the stage and to kind of reinforce the bill, Congress passed hemp as being a legal agricultural product, and the threshold is 0.03% THC, as our good representative mentioned. And anything less, if you will, naturally occurring, and that will become important in a minute, is legal and not to be restricted in any manner. This bill doesn't alter that. This bill doesn't change that, and that's very important. It is not designed to do anything with hemp. It is designed to deal with those items that are being called hemp-related products, when in fact they have been altered, changed, and manipulated. Secondly, the bill doesn't address or doesn't alter a parental relationship to those hemp-derived products that they choose to get and seek for their child. So with that, Mr. Chairman, in keeping in mind, let's talk about what we do find in schools that we do educate on and that we're here to address.
Go ahead, sir.
Hello, thank you, Mr.
Sergeant, is
Chairman.
that correct? No.
No,
Nope.
no, I'm just a detective at the police department here in Cheyenne.
Not just a detective, you're a detective.
There you go.
Go ahead,
I
detective.
appreciate that. The last 4 years before becoming a detective, I was a school resource officer in 2 of the schools in Cheyenne. And I also served some time at the other school, pun intended there. So in the schools, we're noticing that we had an increasingly large drug problem that we're having difficulty getting a hold of. Not just Delta-9, which is the federally illegal substance which is found in marijuana, the Delta-9 THC that we're all used to throughout years past, but this new Delta-8 surge that we were seeing as well. And so, in law enforcement, especially with the kids, we would always joke that this isn't your grandpa's marijuana anymore. The marijuana in the 70s was roughly 3 to 5% potent for THC. And so the joints that people would think of is about 3 to 5%. The marijuana that we're finding primarily in the schools right now that I would find almost on a daily basis was about 80 to 90% THC. And so when they legalized marijuana in Colorado, that's what they legalized as well. So for $30, you can go buy a THC vape in Colorado at about 80 to 90% THC. The school that I worked at last year, I could find a THC vape every single day during passing time in the boys' bathroom. the boys would pass around these THC vapes, oftentimes Delta 8, just pass it around to each other. And about one hit off a THC vape nowadays is equivalent to about 5 marijuana joints of the 70s. So one hit and they're good for a little while. They're also odorless oftentimes, so we would see students using them in class, just blowing the vapor down their sweatshirt, and nobody knows any better. I'm also a drug recognition expert, and primarily a drug recognition expert. DREs are used for roadside impairment. If we pull someone over thinking that they're under the influence of alcohol and we give them a PBC and they blow zeros, they call up a DRE to determine what they're actually under the influence of. Oftentimes we're seeing marijuana, methamphetamine, whatever. And the first time ever in Laramie County, I was trained as an SRO in DRE because we were having difficulty determining and getting probable cause to write kids tickets for being under the influence of marijuana. And so I wrote approximately 100 tickets, something like that last year for being under the influence of marijuana / Delta 8 THC. The problem with Delta 8 that we found is it's not illegal in the state of Wyoming, and it causes all the same drug effects that Delta 9 does. The FDA website, just pulled it off there this morning, says that Delta 8 THC has psychoactive and intoxicating effects similar to Delta 9 THC, the component responsible for the high people may experience from using cannabis. And then they go on to say that the dangers of it. So it is dangerous. Fortunately, in Cheyenne, the city ordinance states that any marijuana like THC or its derivatives, so we have been citing it within the city limits of Cheyenne, the county, and as far as I'm aware, in other places in Wyoming, they don't have that luxury. So it's interesting that we can cite a 19-year-old for using nicotine, but we cannot cite a 19-year-old for using Delta 8 THC and getting just as high as they would off of Delta 9. You can buy it everywhere. I was doing compliance inspections with an underage person last night, walked into a smoke shop here in Cheyenne, and they had more Delta 8 on the shelves than they did nicotine. And the gentleman working was explaining all of it to me, and he talked about, hey, you can get just as high off of this as you can Delta 9, and they're selling it here in Cheyenne. The same smoke shop students at the high school that I worked at would say, as long as you pay cash, they'll sell to anybody. So we have something in place where we were able to check compliance with nicotine. That's what we're doing. We do not have anything in place to check compliance for Delta 8. And these kids are just buying it like crazy. There's a mention of sending kids to the hospital. As a drug recognition expert, some of the same effects for Delta 9 we have with Delta 8. Oftentimes I'll get called to the nurse's office because we have a kid with a heart rate of about 180 beats per minute. As he's falling asleep on the chair, hallucinating, doesn't even know his own name, blood pressure through the roof, dilated pupils over 7 millimeters. And they're looking at me, what should we do? And oftentimes they'd bring the kid to the hospital off of, again, Delta 8, which you can buy here in Cheyenne. So it is an increasing issue, and I'd be happy to answer any questions that you have. Oh, I'm sorry, one more thing that I just thought about. There was some mention about some ways we can test marijuana. We do have what were called in the past NIC kits to test if something had THC in it. And we use those regularly on the street. In the schools, we have a little swab that we can test to see if it contains a high enough grade of THC to cite somebody. And so we test all vape devices that we find using those kits. I just found one again last week. And when I gave my testimony at the House, I actually had court for the very thing for a kid being under the influence. I had to leave early. But so we are able to test with it. We also do have drug testing. Swab kits. I think we have the only one in the state of Wyoming where you can swab their inside of their cheek. Of course, they have to consent to that. It's an invasive search to a certain extent. And within 5 minutes, it says if they're under the influence of THC through an oral swab. I've never heard of the kits or the device that you said, Senator. That sounds interesting.
Questions? Go ahead, Senator Hutchins.
Thank you, Mr. Chair, and it's nice to see the front of you, Josh. I usually just see the back of your head in church, but I appreciate your testimony. One thing that bothers me, and Senator Bouchard alluded to it, is the age of 21. Why don't we just say it's illegal, period, here in Wyoming?
Sounds great, Senator. I didn't write that bill. I think everyone up here would probably want it to be across the board. But I'm not aware of the reasoning or if this is just a baby step.
Thank you, Mr. Chair. If I could, because it seems to me this is something so dangerous. We're saying, okay, if you're 18, you can't do it or below, but if you're 21, you can. So we're putting those people out on the streets. So if you guys can think of something, probably Byron can really quickly, if there's a way we can amend that into this bill, I'd love to just say it's illegal, period. Thank you.
Thanks, Senator.
Response, go ahead.
No, I wholeheartedly agree. The Cheyenne Police Department fully supports this bill and anything we can do to further getting Delta 8 off the street.
Okay, Senator Dockstader.
Yeah, it looks like the title's all encompassing to my fellow senator. It looks like it covers it. So not being as familiar with this as what I should be, where does all the Delta 8 come from? There's like wholesale suppliers. How does it work? It's not illegal now, but there are suppliers putting it into our retail shops, correct?
Yes, Senator. A lot of it does come online, where these shops are getting it. The gentleman that I talked to last night said that the strain of Delta 8, the components in it, were actually invented or put together here in Cheyenne, and they use a distributor outside of Cheyenne to physically put it together to manufacture it, and then they import it into Cheyenne. That being said, if you go to Fort Collins, they have a Delta 9 section and a Delta 8 section at a lot of these head shops. And so a lot of people, you buy some Delta 8, bring it back to Wyoming, and there's no repercussions.
Understood. Thank you, Mr. Chairman.
Senator Bouchard.
Thank you, Mr. Chairman. So here's where I'm having a problem, because THC, if you find THC in a product on the shelf in Wyoming, it's illegal, right?
Yes. So yes.
So follow up, Mr. Chairman.
Go ahead.
So, I'm just a little worried that we have a situation where we have a kid that takes a product here, tampers with it, and now we've created a big mess, and people are pointing at each other. And how do we, if it's already illegal to have it or to sell it, why is this necessary if it's already illegal? That's what I'm trying to wrap my head around here.
Yes.
Go ahead.
Thank you, Mr. Chair and Senator Bouchard. I think the confusion is that Delta 9 is illegal. So Delta 9 is federally illegal. Ask Colorado, maybe it's not, but so Delta 9 is illegal. Delta 8 is not listed within the Wyoming state statute as being illegal. So we have nothing saying it's my understanding that Delta 8 is illegal. It's not even mentioned. So right now, there's nothing limiting anyone selling Delta 8 in the state of Wyoming, with the exception of a city ordinance here and there.
Mr. Overcoat, you got something to add?
Mr. Chairman, if I may, for a degree of clarification at this specific point. One of the dilemmas that we have is that the hemp industry did just exactly what they said they wouldn't do. Or I should say some of the bad actors did. And that is that they synthesized the Delta 9 into a Delta 8, which isn't listed, and are marketing their CBD gummy bear to have the ability to be euphoric, to get a high. Much as we wrestled with, for those of you who've been here for a day or two, it seemed like every year we would come before you with a spice bill, with yet another formula that the folks had derived that we didn't have on the books, that was now legal, that's legal because it wasn't on the books, that we would say, let's make this page of formula illegal so we can go deal with that. We're kind of at that issue. And I would point out that the hemp industry during our testimony in the House confirmed that. The good representative of the industry there said the bad actors did just what we said, asked them not to do. And that is to synthesize, and that's the part that I think is important, to synthesize a product and then put that in the gummy bear, if you will, advertise it and deal with it. The dilemma that we have in testing or learning is two-pronged. One, right now they're advertising it to their advantage. So when you look on the label, they're putting Delta-8 at 2.97% THC. So that they're saying it's underneath the threshold. The dilemma that we have is the testing works well for green leafy material. Very well. It's very inaccurate in all other tests. What I believe the good senator was referring to on a larger scale is the mass spectrometer to be able to look at identifying compounds within. And the testimony before the Joint Judiciary a couple of years ago by the leading expert in Colorado said their ability to test marijuana or THC within a gummy bear was plus or minus 50% accurate. Plus or minus 50%. They could tell it was there, which again is our threshold for illegality, but not the percentage as it related to a hemp discussion, Mr. Chairman. So it becomes rather complicated, and this discussion is attempting to say for under 21 that CBD vape and gummy bear is going to be illegal, and all your tetrahydrocannabinoid synthesized derivatives are illegal, period. So there's two pieces to this that we need to focus on. And the third piece of that is that for parents who want to, if you look on page 4, line 14, I believe, if I call it back up here quick, nothing will interfere with the parental ability to administer or deal with any CBD products as well. So I think we have parts of those covered in our desire to make the vaping and gummy bears that we find in schools, the kids are overusing, and I'm sure the good Sergeant Nelson, who should be next, will help corroborate the discussion that the gummy bears marketed in Colorado are designed to be cut into 1/10. I don't know anybody who's going to eat 1/10 of a gummy bear. And the problem with the stomach is it metabolizes slowly. So you eat one, nothing happens. Eat a second one, nothing's happened yet. Eat a third one, we still aren't there yet. How about the rest of the bag? And pretty soon we're being described and hauled off to the hospital, much as being described. So, Mr. Chairman, I could go on for a while, but I think I'll pause there. Let the good Sergeant Nelson and Ms. Parsons discuss and circle back in a minute.
Very good. And I would tell everyone that we've got about 15 minutes or so left, so we want to make sure to move this forward as we can. Senator Hutchins, or Bouchard, I'm sorry.
Thank you, Mr. Chairman. So, see, where I'm seeing this is this bill may not be the right vehicle, because if you just go back into the other code, I think we have to have something broader that says anything that they come up with synthetic. And so that's where I'm having the problem, because I don't want the mess of who did what and pointing fingers and everything else. And if it, so does that make sense, Mr. Odekoven?
Go ahead, Mr. Odekoven.
Thank you, Mr. Chairman. And if you look on page 6, line 6 through 9, was the additional language that we added in the House based on exactly this point. And that is to rope in the all-encompassing definition of psychoactive component of the cannabis plant with the scientific name of trans-delta-9 tetrahydrocannabinol. So that is, I'm hoping or hopeful, that all-encompassing definition that accomplishes that very goal. So that I'm hoping next year we don't come back with another page with another definition. Mr. Chairman.
You underestimate the chemist, but go ahead, Senator Bouchard.
Well, I just want to add, I have a constitutional problem with this bill, because the title says minors and age is 21. Under Wyoming definition, it's 18 is what a minor is. So I have a constitutional problem with the bill. So do you have any problem with going to 18 on this? Because that's the only problem I have with the bill.
Mr. Odekoven.
Mr. Chairman, as the good Representative Newsom indicated, This follows the same path of alcohol and tobacco. And that is that it's regulated to age 21. So the bill is designed to pattern itself after that, so that we're having a age 21 discussion the very same manner that we do with alcohol and tobacco.
Thank you, Chair. You know, the only thing that I would add as far as the edibles, the concern for those, I know we have a limited amount of time, but I think it's important to know that the stomach has a valve on the bottom called the pyloric valve. Maybe you know this, sir. And so liquids are able to flow freely. When you're eating food, that pyloric valve closes, and so your stomach tends to fill up. Unfortunately, THC is metabolized in the liver. So as these kids are eating a half a gummy bear, right? They're eating a full gummy bear. They're not feeling the effects. So like we heard, they continue to take more and more and more until that pyloric valve opens. Everything's metabolized in the liver at the same time, and they get a rush of highly concentrated THC. So that's the danger of edibles that a lot of people don't recognize.
As opposed to vape, which it goes into the system immediately.
Yes, sir.
That's a huge difference, the mucous membranes. Okay, with that in mind, go ahead.
Chairman Baldwin, members of the committee, my name is Rhea Parsons. Just really quickly, I wanted to share a data source with you if you are not already aware of it. It's called the PNA, it's pnasurvey.org. It comes out of the Wyoming Survey and Analysis Center, so it's the Prevention Needs Assessment. And what they do is they go in and do a survey with majority of the school districts in Wyoming where youth self-report, 6th, 8th, 10th, and 12th graders self-report on use. And I share this with you in that I was just looking quickly this morning about the age at which youth begin take their first vape. And so about 72% of students have not. In the 2022, we just received the 2022 results, 72% had not, but that does mean that 20% of students, so close to 1 in 3, have started vaping. And when we take a look at the age that you know, they ask them whether they start at 10, 11, 12, all the way up to 17. The highest percentage of students when they take their first vape is 13 years old. So when we take a look at that, and they're most likely starting with some type of fruity flavored nicotine and essentially making their way up to THC, and why we're seeing the problems in the high schools. Also, they also ask the question how the students are receiving, how they obtain the devices, and while they do obtain some of them from the stores, oftentimes they're obtaining them from friends or people that are older than 21. So from a prevention standpoint, evidence-based strategies around this topic always include restricting availability to youth and holding those accountable that provide those substances to youth. And so, of course, we like anything that restricts the substance overall, but we also like it is an evidence-based strategy to hold those accountable that serve those substances to those that are underage. So that's it on my end.
Questions, committee? See none, let's move online real quick and see if we can bring Sarah Nelson in, please.
Mr. Chairman, we have Richard Jones. I'll admit him to testify.
Go ahead and bring, how many do we have online? 2, let's bring them both in. Can you hear us?
Yes, sir, I can. Thank you.
Go ahead, Mr. Jones.
My name's Richard Jones. I'm in Cody. I've been involved with prevention for a long time. I really appreciate allowing the testimony here. I have no disagreements with most everything that has been considered by all your panelists. This is a serious problem. It's of great concern. I commend Representative Newsom for trying to follow this through. She had her own bill she tried to amend a few times, but it didn't make it out of the House. I want to address the bill directly. So much of the commentary has been here on the use of these products and everything else. This bill, as written, only prevents the sale of these substances as redefined. The problem is there are no consequences for minors possessing, using edibles or vaping devices. And the actual use or possession of edibles and vaping devices is at the heart of the problem. And as Ms. Parsons says, that surveys show that these youth are not getting their stuff walking into a store and buying it. They're getting it from friends, from parents who may have it. And unless there are some consequences of some sort to prevent possession, use, or purchase by minors, such as there is with alcohol and tobacco, this bill won't have much of an effect on reducing the use and access by youth. As a school resource officer under this bill, the only person who could be charged with this is a person who sold it to the student. The student has no consequences for possessing a device or possessing the product. And I sent each of you just a small synopsis of this, but also a proposed amendment that would make possession or use or purchase of vaping devices or edibles by a person under 21 years of age prohibited. I agree with Senator Bouchard that it should be illegal for everybody, but that's a different issue. But without this consequences for youth, I don't see how a school resource officer or an officer stopping a vehicle suspecting DUI with marijuana, they have a device in their hand or something else. There's nothing in the law that makes that illegal for that minor. There are no consequences. So I also sent each of you an email with a proposed amendment, which is exactly almost the same as one that Representative Newsom tried to amend her bill with, that says that purchase, possession, or use of vaping devices or edibles by a person under 21 is prohibited. And the penalties involved for that almost follow exactly the same penalties outlined in existing tobacco statutes. In other words, it's not a criminal thing, it's a citable offense. There's an ability to expunge that record after 6 months if there are no further citations. So the criminal aspects of it aren't there for youth, but actually having those things in their hand is illegal. That's enforceable, and that keeps it out. I appreciate your time. I'll stand for any questions at all, but I think this bill as written now does not address the problem of keeping it out of the hands of youth.
Thank you very much, sir. Quick questions. Go ahead, Senator Hutchins.
Thank you, Mr. Chair. Sir, on page 2, lines 1 through 4, I see no person or retailer shall sell, permit the sale, offer for sale, give away. So if we see no person shall give away, do you think that includes any youth?
Go ahead, sir.
So the child has, I'm sorry, Mr. Chair, addressing Ms. Hutchinson. The youth has this product. They have a vaping device in their hand of some sort, and it came from somewhere. And the child says, well, you know, a friend gave it to me, or I stole it from my parent or something else. It was not given to them. And proving that kind of thing is exceedingly difficult. And I'll direct you to the online sales. If you go to a site called Sky High, very easy to remember, S-K-Y High, H-I-G-H, out of Ohio, an online retailer, their site is specifically designed for children. Their logo is a child of about 12 years old, looks like he's parachuting out of an airplane with a big smile on his face. And they specifically say they won't sell any of these products, Delta 9, Delta 8, or anything else, to anyone under 21. And when you go to their age verification check, when you order it, they have a little box there that says, are you over 21? Yes or no? Well, you just check no, and you get the product. So the possession of the product itself or the devices itself, if there's no consequences for the child to have these things, I don't see how it can be enforced or restricted or used. So the retailer is pretty easy. Like alcohol, you go in and have an alcohol check or a tobacco check, as the enforcers do, send in an underage person and they get it without a proper ID. The retailer's in trouble. these kids by and large aren't getting these products walking into the store to get them. Somebody who is older does, and then they give it to this child, or they go down to Colorado and bring it back. So from an enforcement and a restrictive point of view, trying to keep it out of the hands of kids, I don't see where this bill, as laudable as it is, will not have that effect. So I think it needs to be amended to that effect.
Okay, thank you very much. You'll hold off for just, yeah, we'll do it in discussion if we can. Yeah, okay. Look, quick question, Senator Bouchard.
Mr. Chairman, thank you. So when I look at this bill and I go to page 2, between line 1 and line 4, it says no person or retailer shall sell, and it goes on, but it doesn't say, it doesn't define what we're restricting here in this first line. This says edible products or vaping products. So if somebody has a CBD edible, they can't sell that either, even if it's been triple certified that doesn't have THC. That's where I'm having the problem here. That's why I think that this bill kind of doesn't do what we needed to do. It's going after something that is already being sold, and even to the retailers that, because I went into these retailers and I've talked to them, and I have a CDL. So when I went, and if anybody has watched, when I opposed that bill that they were trying to get rid of the hemp products, I had CBD products and I was eating them in committee. So I had to be very careful that I wasn't taking in THC, and I needed some clarification from the seller of these products, and I got them. And so my point is, this is broader than what we're trying to do here, and that's where I see a problem.
Mr. Ortico, when you had,
Quickly, Mr. Chairman, I would just offer that you cannot pass a statute that would restrict the legal CBD. This bill doesn't do that, in our opinion. We cannot use this statute to deal with legal CBD because it shall be unrestricted, period.
a huge problem here.
Mr. Chairman, I hate but I'm looking at what it says. Sale or offer for sale, give away, or deliver edible products or vaping products to any person. It doesn't say products that are tainted with. It doesn't say products that have these items that we're trying to target. That's where I see the problem is in this legislation.
Okay, let's go ahead and take testimony from Sarah Nelson. If she's still there, let's please bring her in.
Yeah, Mr. Chairman, I've admitted Sarah Nelson.
Okay. Sarah, can you hear us?
Sarah just needs to turn on her mic and her video.
Yep. Turn on your mic and your video if you can hear me. We can see Mr. Jones, but we've already heard him.
Okay.
Okay, we hear you and we see. Go ahead. We're about out of time, so if you can really make it quick, we'd appreciate it.
I appreciate it. Good morning, Chairman and members of the committee. I'm Sergeant Sarah Nelson with I'm the sergeant over the SROs for Casper. And I have about 13,000 students, and there's 6 SROs that manage those students. We've had numerous issues with not only the Delta 8, but some of the other synthetic derivatives of that. And we have THCO, THCP, Delta 8, Delta 10, Delta 11's coming out. So there's other products besides the Delta 8 that we are starting to see. I'm just going to let you know, I do have, there are 14 other states that have banned Delta 8 and a lot of the isomer products that are coming out. So there are multiple states out there that also recognize that this is an issue. And there's also a handful of states out there that have restrictions, such as we are trying to do with these bills, the 137 that went through and with Representative Newsom and also this one. So it's not just Wyoming that is dealing with this, it's all over the nation. There's thousands of calls to poison control due to this issue for kids 12 to 17 years old, as well as the FDA has put out warnings for this. I agree. I wish we could ban this stuff. It's no different than the spice products that we've been seeing, years ago, where they just kept changing it. But I would like to, I had an SRO talked to me about a 14-year-old. And if you don't mind, I'd just kind of like to go through that, what we've seen with him. He sent this to me. He said, I contacted a 14-year-old heavily under the influence of one of these products. This was Goliath London Pound Cake. This was a vape product. It contained CBD, Delta 8, Delta 10, Delta 9, with a total of 723 milligrams of cannabinoids per gram, so 72.3% per gram. So he went to the website and it says that THCH is 10 times more potent than THC in its psychoactive capabilities. None of these compounds fell under the definition of our Delta 9 definition in state statute. So we're unable to do anything with this product. But as he started looking, and we do this when we contact any of these substances, we start looking on the website. They specifically target youth for sale of these products. So as we were talking to this child, he said, in this case, he could not form sentences, had difficulty communicating. At one point, he began crying and explained when he started using these THC products, one day the high just didn't go away. Nothing feels real anymore. The juvenile earlier reported to be dealing products like this in the school, but later retracted the statement. Regardless, none of the chemicals listed are currently controlled and no enforcement action was available to us. The Delta H was under the legal limit of the 0.03. So, excuse me, the Delta combination. So we still couldn't enforce this. So this is what we're seeing. We've gone to our head shops. We've talked to owners of those shops and they said, yep, we know what the state statute is here. And they laughed at like, well, we don't have one, so we can keep doing this basically. So yeah, it is a huge problem here. We've had kids that are completely incapacitated where they can't stand up, they're drooling, they can't form sentences. Because again, they don't take just one gummy or one Skittles. There are brands out there that mimic candy and have Skittles on there and a tiny little corner that says Delta 8. These kiddos will not just eat one Skittle, they eat the whole package. And basically, they are sent to the emergency room with poisoning. Not considered overdose, more of a poisoning type situation. So I agree with what the detective said. I agree with Mr. Jones. This does not cover the possession. I know House Bill 137 was working towards that with these isomers, but this will at least limit the sale of it in our communities. And hopefully, if we can't change the bill to add possession, that one shortly will follow.
Okay, questions, committee? Seeing none, was there one more person online? We're done with the people online, okay. Is there anybody else? Quick testimony because we need to get this voted on and get to the floor. Mr. Winnie, go ahead, sir.
Yes, sir, Mr. Chairman. Thank you very much. Bill Winnie, Sublette County. I'd like to give you a slightly different perspective. I've been trained on THC as a commanding officer. You've heard it all. I don't need to go over any of it. In the submarine world, we can operate our ships isolated from the atmosphere for weeks to months. We pay a lot of attention to airborne particulates, oils, and vapors, and that's what's going on with these vaping products. And those are developing lungs. And I think to the extent we can keep this stuff out of them, that's a good thing. I support the bill, subject to your questions. Thank you.
That was very quick. That was very good, Mr. Winnie. Questions for Mr. Winnie? He's getting good at this. Yeah, Joint Fractions, go ahead, Mr. Representative.
Thank you, Mr. Chairman. As testified by a couple other people, I brought an amendment to this particular bill that would be listed on the amendments that failed, that would have the penalties for possession. And if you would consider bringing that amendment back, I would appreciate it. Thank you.
Okay, if there's no further testimony, let's go ahead and close this to Public Testimony Committee.
Move the bill.
Moved by Senator Dockstader, seconded by Senator Hutchings. Comments, discussion, amendments?
I'd like to entertain Representative Newsom's amendment on the floor if I could, if she gets that to me.
Let's do that. Let's do that as a committee of the whole amendment.
Got it?
Anything further, committee?
Appreciate Representative Newsom for picking up where she left off. It was very selfless of her to carry this work forward. Commend her for that.
And she's handicapped today to boot. Senator Bouchard.
Thank you, Mr. Chairman. So we're on page 2, between line 1 and 4, where it says vaping products, I mean, I think it should say that contain substances cited in 143310. That would make the bill uniform as to what the product is we're trying to target.
Any comments on that? Was that a move?
Yeah.
Okay. Did you get that? Go ahead and repeat that for.
Or if there's a better way to say that, but you get where I'm going with this.
Go ahead. just-
Maybe even Mr. Odekoven.
Mr. Odekoven, suggestions, comments on that?
So after, on line 3, after vaping products that contain substances cited in 143310, which is in definitions on the following page.
Go ahead.
Mr. Chairman, I believe the definitions is 301.
Maybe I had it wrong, but it would, yeah, let me look at it. Is it 301?
Yeah.
Yeah, okay.
The definitions are found on page 5.
Yeah.
And
So,
301.
yeah, 301. I just misspoke here.
And that would be my contention is that since it is on section 5 in the definitions, and which includes everything in the article, or everything in the bill, we've already effectively done that. So we've probably already done it.
Mr. Chairman, I don't agree because it doesn't cite in this act on this line. This line, I mean, I think Mr. Odekoven would agree that if you just take this standalone, it would be any edible product.
Okay.
So that's what I'm concerned with. So I would appreciate it if Mr. Odekoven gave a little scope of clarity there and help me get my head around this.
Go ahead, Mr. Odekoven.
Mr. Chairman, with all due respect, I'd need a moment with an attorney to double check and make sure we're good, or that may be a great moment on committee of the whole for.
I was going to say, how about we
clarity.
consider that as committee of the whole, if you'll entertain that? That'd be fair.
Because I would hate to put something in that messed up the deal. So,
Okay,
Mr.
so
Chairman,
let's get heads together outside of the room here. If this bill passes, well, with both of you and with you and you, and we'll put it together as committee of the whole amendments. Perhaps we could even put that on one amendment. Make it together. Okay, very good. Anything further, committee? With that, let's take a vote.
Thank you, Mr. Chair. House Bill 108, sale of THC vaping devices and edibles to minors prohibited. Senator Barlow is an aye. Senator Bouchard. Aye. Senator Dockstader.
Aye.
Senator Hutchins. Chairman Baldwin.
Aye.
Sir, we do have 5 ayes.
House Bill 108 has passed the Labor and Health Committee. And since my name's on there, I guess I'll present that one.
Thank you.
I'll pick on myself today. And if you guys can get together and, okay, this committee meeting is closed. We're going to go off to our next meeting. Thank you very much, especially Sandy, to you.